Good afternoon, everyone, and a warm welcome to today's online edition of the Victorian COVID-19 and Cancer Network Monday Lunch Live webinar. My name is Wong. I'm a medical oncologist, and I currently head the oncology unit at Peninsula Health, and I'm also the co-clinical director at the Southern Melbourne Integrated Cancer Service. Before we start, I'd like to acknowledge the traditional custodians of the land on which the Victorian Comprehensive Cancer Consortium and the Monash Partners Comprehensive Cancer Consortium are located. I'd also like to pay respect to the elders, both past, present, and emerging, of the Kulin Nation, and extend that respect to the other Indigenous Australians present online. The Victorian COVID-19 and Cancer Task Force is a collaborative initiative between the VCCC and the MPCCC. It's co-chaired by Professor Grant MacArthur, Associate Professor Sue-Ann McLaughlin, Associate Professor Andrew Hayden, and myself. And the first webinar was held on the 23rd of March, just 2 weeks ago, and was very well received. We had more than 900 attendees, and we will be having more sessions in the coming weeks, and we'll be showing you that schedule in the next slide. Just a housekeeping issue before we start. You can ask questions to any of the presenters whom we have today via the GoToWebinar platform, and you could do this throughout the presentation. Now, first I'd like to introduce our first panelist, Dr. Benjamin Teh. Unfortunately, sorry, beg your pardon. All right, so if you can see on your screen, this will be a button to send through your questions via the GoToWebinar, either on your laptop or on your smart device. Next slide, please. So our first speaker is, so this is just some information for you to join. And our first speaker is Dr. Benjamin Teh. He's an infectious disease physician and a clinical researcher at the Peter MacCallum Cancer Centre and at the National Centre for Infections in Cancer. Unfortunately, we're not able to see him, but he's online as the webcam didn't quite manage to get that work. Apologies. His research interests in the area of infections in cancer patients encompass both translational immune profiling for infection risk prediction, clinical studies of infection risk with new cancer therapies, and clinical trials of prevention measures such as vaccination in hematology patients. Ben will talk to us today on the immunology behind susceptibility and how cancer treatment may leave the immune system of our patients potentially vulnerable to the COVID-19 infection. Ben?
All right. Thanks, Z, and thanks for the kind introduction, and also to the organizers for inviting me to give this talk to you all today. So the area that I'm going to speak on today is basically why our patients with cancer are potentially at higher risk for COVID-19. And certainly, thank you for accommodating my clinical duties. And so we'll leave questions to the end of the talk, if you don't mind. So I think one of the key things I wanted to highlight is certainly, even before the outbreak of COVID-19, I think, in terms of patients with cancer and respiratory viruses, that unfortunately we do know that patients with cancer are at higher risk for respiratory viral infections. In particular, with hematology patients, there are certain key groups that seem to be potentially at higher risk, including patients with multiple myeloma, CLL, those who have undergone autologous and allogeneic stem cell transplant. And we do see from quite good data that there's actually even progression from what the concern is, of course, that patients start out with just more simple upper respiratory tract type symptoms, and then it progresses to a more severe infection involving the lower respiratory tract in up to 30% of patients. Unfortunately, the data is not as good in oncology patients, where potentially the highest risk period, where we do have data is perhaps in patients with lung cancer, where the highest risk period for these patients seem to be in the first 6 months of lung cancer diagnosis. In the early studies that are coming out from China in particular, there seems to be a higher incidence of patients with cancer when they look at a whole population of patients who do have COVID-19. So I think there's certainly some indication of risk there. So when we sort of dive into that data a little bit more, especially there's been a small case report from Liang et al. Published in Lancet Oncology that in this sort of case series, lung cancer seems to be the most commonly reported cancer group. But again, I think we have to remember that it could be publication bias as well, and it depends on which group gets out their data first. But what's interesting is that, lung cancer seems to be the largest group amongst all cancers that have been reported in this case series. There seems to be more rapid deterioration, unfortunately, where patients with cancer in particular have progressed from mild disease to more severe complications at a median of 13 days as opposed to 43 days if people don't have cancer. They, in general, are at higher risk for severe disease. Patients with cancer are up to 3.5 times higher compared to someone without cancer. And interestingly, if you particularly have received cancer therapy or surgery within the last 30 days, there's also a higher risk of having what the authors have deemed to be a severe event, which is essentially needing to go to ICU or needing additional supports like higher amounts of oxygen. So, and that could be up to 5 times the risk of as well. So unfortunately, looking at what we call the CFR, which is the case fatality ratio, that this seems to be at 5.6% if there's a history of cancer. So as Zee had highlighted, part of the talk is talking about the immune system. And so there's this early publication out of actually a Melbourne group looking at the immune response to SARS coronavirus 2, which is the virus that leads to COVID-19. And I think the breadth of immune response in a patient that has COVID-19 is quite typical of what we call a multi-arm immune response, where there's an increase in antibody secreting cells, the activated CD4 and CD8 T cells, which help to fight infection, are mobilized. And then very typically as well that we see the development of very specific antibodies, starting with the early response, which is an IgM response, followed subsequently by a more sort of deeper response, which is the IgG antibody response. So the response of a patient to this virus is quite typical for a response to respiratory viruses and to infections in general. And certainly as we go through this presentation, we'll see how patients with cancer might get affected in different ways. So how I normally, when I assess someone for risk of infection, I like to think of it in sort of 3 big groups. 1, patient-related factors. 2, what treatment they've received for cancer, and 3, disease-related factors. And I think they all feed into each other as well, and I'll run through them as we go. So I think when we look at the reasons why patients could be at higher risk, cancer patients could be at higher risk for COVID-19, 1 is age. I think there's through all the studies that have come out of, in particularly China, that we certainly have seen that age is a major risk factor for, unfortunately, a poorer outcome from this infection. So overall, the case fatality ratio is 2.3% if we look at everyone. But as you can see on the slides, it certainly goes up as in the older age group to 8% and up to 15% if 80 years and higher. And so that unfortunately we do know that in general patients with cancer do belong to an older age group. So in itself, regardless of the cancer history, this is a risk factor for one, developing the infection, but also developing a poor outcome from this infection. The other the other patient factor that is also important, which share a lot of commonalities in our patient group, is having what we call comorbidities. So other medical problems. In particular, what's been found through studies in COVID-19 patients is that if you have another or multiple other medical issues, unfortunately, it leads to a poorer outcome as well. So some of the comorbidities that have been found includes high blood pressure, cardiovascular disease like heart disease, diabetes, and certainly particularly in association with smoking and a smoking history. So one of the other big groups is disease factors, and I think in this instance it really depends on the type of cancer we're talking about, and what about that particular cancer type that leads to an increased risk for infection. So, for example, in solid tumor, again, in particularly with lung cancer, why potentially someone with lung cancer could be at higher risk is because the anatomy of the area could be altered. For example, there could be compression from the cancer leading to collapse and a higher risk for developing pneumonia. If someone with lung cancer has had surgery, especially lung surgery or radiotherapy, there could be reduced physiological reserve to cope with a lung type infection. That could be an additional factor as well. The type, like I said, the other on the other side of things, in terms of blood cancers, in particular, more long-term blood cancers like myeloma and chronic lymphocytic leukemia, it's because the disease themselves can actually contribute to problems within the immune system. So because these immune cells themselves are affected by the cancer, it leads to actually problems with numerical and functional deficits in different arms of the immune system that we rely on to help fight infection. So, for example, in patients with myeloma and CLL, the monocyte and NK cell function might be impacted. There's often impaired what we call T cell responses. So these are the CD4 and CD8 cells that are specifically, you need to help to fight viral infections. And also, as a feature of the disease, some of these patients could also have what we call low immunoglobulin levels or hypogammaglobulinemia. So that all together can increase the risk of infection. As you can see from these 3 points that I've highlighted, back to the previous slide about the immune response to helping to fight, the SARS coronavirus 2 virus. These are, different arms of the immune system that get affected as well. The other disease, I think, factor that we always need to think about is what we call disease burden and status. So obviously, unfortunately, if a patient has more progressive disease or refractory disease which is not responding to treatment, there's often, we do know that in that instance, there's increasing immune dysfunction because of the disease not being under control. And so then that also leads to an increased risk for infection. So in terms of treatment factors, I think these are a little bit more straightforward to explain. Obviously, the type of treatment that we use for the cancer can impact on risk in different ways. For example, in particular, 2 types of agents that we would highlight. One is, of course, corticosteroids, which are the mainstay of quite a number of hematological treatments. Steroids are very good for helping us treat cancer, but unfortunately, it also impairs our ability to respond and to fight off infection. So the other type of treatment that we often highlight are stem cell transplants. More because, to prepare people for stem cell transplant, you give very strong conditioning therapy, and therefore then it takes a period of time before the immune cells can slowly start recovering, but over a period of months. So as part of the immune recovery, you then are at increased risk because the immune system has not fully recovered following a stem cell transplant. Then there are, of course, treatments that are associated with particular immune deficits. Some conventional chemotherapy, especially depending on the dose and depending on if you use combination conventional chemotherapy, can then lead to neutropenia. which is a low white cell count, and depends on the type of chemotherapy they give and the combination, this can be quite prolonged as well. And so the longer it is and the lower it is for these cell counts, in particular neutropenia, but also lymphopenia, then the higher the risk of infection. The other treatment factor that we often have to think about are complications of therapy. So, for example, again, highlighting the example of stem cell transplant, for example, graft versus host disease in itself can be quite immune suppressive. So these are some of the factors to think about. Now, the issue with all that I've discussed so far are these are general risk factors for developing infection, and some of these highlighted are also risk factors for respiratory viral infections in a typical year, and not necessarily just related to COVID-19. So as we learn more about this outbreak and this virus, that there might be more nuanced or newer risk factors identified, but certainly these are general risk factors that we do know from year to year that increases people's risk for respiratory viral infection in the cancer patient group. So there are actually different studies in if you like, in a normal or seasonal year for respiratory viral infections. So people have tried to develop a way of scoring someone's risk for infection, and of all the risk factors that I've previously discussed. And there's actually this particular scoring index called the immunodeficiency scoring index. But again, there's several caveats that we have to bear in mind, that this index was developed, one, for stem cell transplant patients, two, developed particularly for respiratory syncytial virus infection. It has been tested out and validated for influenza virus infection, but certainly by no means it's not validated, or it hasn't been tested as yet for use to predict patient outcomes for COVID-19. But potentially it could serve as a useful guide for when we see patients to see if we can perhaps identify higher risk factors that then make us highlight the increased need to observe a patient particularly more carefully. So this immunodeficiency scoring index was developed actually to weigh out someone's risk for progression from upper to lower respiratory tract infection, which I highlighted earlier, in an earlier slide, that this is a more severe form of infection and a more severe, and potentially can lead to a more severe outcome, and also the risk for progression to mortality. So it highlights, this risk index uses some of the risk factors that I've already highlighted it incorporates patient-related factors, disease-related factors, and treatment-related factors. For example, low neutrophil count, low lymphocyte count, a higher age, the type of chemotherapy that you're getting, complications of treatment such as graft versus host disease, and use of steroids, especially within the last 30 days. So by using the score, people have been able to basically put patients into a low risk group, a moderate risk group, and a high risk group. But again, I need to highlight that this was developed for stem cell transplant and not for COVID-19. I know that there's quite a number of questions that have already come through about different scenarios. I thought I would just use this slide to highlight that what is actually not known about risk factors for this outbreak. Certainly, I think we don't know the impact of non-conventional chemotherapy, and what I mean by that is, for example, immune-based therapy, such as immunomodulatory drugs, which are not classically immune suppressive, immune checkpoint inhibitors, targeted therapies such as Bruton tyrosine kinase inhibitors or tyrosine kinase inhibitors themselves, and monoclonal antibodies. I think, unfortunately, even in a non-outbreak year, there's actually not a lot out there in terms of weighing out or evaluating the risk of these treatments and the risk of respiratory viral infection. And so I think there's certainly not enough data out there to really know what their impact will be and on someone's risk for developing COVID-19. I think the other key unknown is about reducing immune suppression and therefore then its impact on risk. So I think it always comes down to a case-by-case discussion, and I think weighing out for the individual patient the impact of having uncontrolled disease or uncontrolled cancer, which in itself is a risk factor, versus the risk of the infection from the treatment itself. I thought I would just highlight that in this table that these are some of the risk factors, some of the initial indicators for a severe infection when someone presents with COVID-19. Certainly, for clinicians, the vital signs thing won't surprise us. Having a high respiratory rate, poor oxygen saturation, and a high heart rate would be in line with what we expect clinically. Some of the laboratory findings that people have reported include, a very high CRP, elevated troponin, very low lymphocyte counts, and very low neutrophil counts on presentation. Is at least an initial indicator for a poor outcome. And unfortunately, in terms of mortality, they certainly have had some people have had a look, and there are certainly some, again, biochemical markers that are associated with higher mortality for someone with COVID-19, in particular with higher interleukin-6 levels, higher CRP, and higher troponin levels. So I'm going to end my talk soon, but I thought before I finish off, I think rather than being too prescriptive, I know there are lots of treatment guidelines out there, and certainly, expert groups are putting out treatment guidelines as to what can or should not be used for treatment of COVID-19. But I thought I'll just run through the general principles of how a patient with cancer should be managed. And I think it's always important to remember that in patients with cancer, the causes of fever and respiratory symptoms are very broad. I think we shouldn't forget that there are other respiratory viruses out there, especially during winter time. There's the risk of influenza virus, RSV, which is a virus that I mentioned before. These are important viruses that we should not forget are still present. I think we also need to remember that when people do develop respiratory viruses, they can be at risk for secondary infections, such as secondary bacterial infections, and in some higher risk groups, for example, even fungal infections. So I think it's important to remember about those other potential infections as well. I think the second point is also very important, that there needs to be very early recognition and treatment of sepsis, because it can be a feature of COVID-19, but obviously sepsis in itself is associated with higher mortality. So I think it's very important that we do recognize a septic patient and manage accordingly with early fluid resuscitation, early institution of antibiotics, and commencing our workup. There's actually point 3, which is the overlapping syndromes. I think it is very important for us. It is important, but it's also a challenge for us that there are often a lot of overlapping syndromes. That we do know that, for example, having pneumonitis related to checkpoint inhibitor can, on appearance on CT scan and clinically, can look very similar to a viral pneumonia. Having therapy-related cytokine release syndrome can also, for all intents and purposes, look very similar to infection-related hyperinflammation. So I think that's the challenge for clinicians at the moment, is dealing with these overlapping syndromes. And I guess one of the things I wanted to highlight is not to just focus on one or the other, but to consider the several possibilities when it comes to similar appearances, especially on radiological findings. I think the sort of final point is about cessation of cancer therapy. I think it is important to, like I said, weigh out the risk of ongoing immune suppression from the therapy, but also to weigh out what then that contributes to in terms of risk of ongoing risk for infection. The other possibility is to look at drug-drug interactions, especially if patients can participate in clinical treatment trials for COVID-19, because some drugs might need to be stopped because of the potential for drug-drug interactions. I'd like to sort of point the audience to a really useful guidance document that our center has been a part with Rob Weinkoff and Zoe McQuilton, which is now out in the Medical Journal of Australia, which gives it's a really good interim guidance document on just broad principles on how we should approach the care of our patients with cancer during COVID-19. And it covers a lot of areas from not just specific therapies, but transfusion, palliative care, and radiotherapy as well. So with that, I might finish up my talk and take questions.
Thanks very much, Ben. That's a very comprehensive review of how the anti-cancer treatment really leave our patients vulnerable, particularly during this pandemic, to the COVID-19 infection. We have just under 300 attendees for the webinar, which is amazing. There are quite a few questions that have come through, so I might actually take this opportunity to ask Ben before he needs to zip off to the clinic. There was a question asking about the way that these treatment leaves our patients immunity suppressed with chemotherapy, but on the other hand, with the checkpoint inhibitors, our patients may have a more active immune system. So, Ben, would you want to advise us, or advise those of us in the audience regarding patients receiving immunosuppressive therapy? Should we be stopping, delaying, or interrupting it? And is that different for those receiving immunotherapy?
Yeah, thanks for the question, Zee. It's a very difficult and challenging question to answer. I think, one, in terms of whether it leads to an increase or a decreased risk for a viral infection or respiratory viral infection like COVID-19, I think we're not sure. And that's the quickest answer. The issue about whether it should be stopped or not, I think it's always a very challenging one. I think it needs to be an individual patient level sort of assessment, because if someone is doing well and is having good disease control on immune therapy, then you sort of would be loath to stop that, to then potentially risk exacerbating the problem. So I think it is unfortunately a case-by-case discussion, and I think it's hard to have a broad recommendation that people all should stop immune therapy or should continue. I think it depends on unfortunately a very individualized scenario.
Sure, thanks, Ben. I'll also add that there are guidelines.
Yeah, I'm sorry, that's not a very detailed clear answer.
There, including the guidelines recently published through COSA by the group from Monash, as well as guidelines through ESMO and ESCO as well. Just one quick one before you zip off. Could you tell us the role of interleukin-6, and perhaps if there is any benefit in using the monoclonal antibody tocilizumab? I hope I pronounced that correctly.
Yes. So thank you. That's actually an interesting area, and it's an area for clinical trials, especially clinical trials of COVID-19 therapy, or at least patients with more severe complications of COVID-19. There's certainly early data out that show that patients who have a more severe manifestation have higher levels of interleukin-6 as part of a hyperinflammatory syndrome, or ARDS type picture. And so there's certainly lots of interest and in terms of if you use an anti-IL-6 agent like tocilizumab, that you could then lead to a better outcome, because you then switch off the hyperinflammatory syndrome or the cytokine release syndrome. Certainly the early data, and these are I think we should be very careful because these are very small case series that have been published, and a lot of them have been put out on the internet peer review. But they appear that people have in these case series seem to do better when you do use tocilizumab in terms of at least, for example, these are severe patients with severe infections coming off mechanical ventilation, and sort of normalization of some of their blood parameters. But again, I would just caution that these are case series, and there's always a risk of publication bias, because obviously people like good messages, and so I think. But I mean, that being said, the use of tocilizumab is being studied in actually quite a number of clinical trials around the world, including here in Australia. And so I think it remains to be answered, but I would only recommend that this be used in the context of a properly evaluated trial, and not just be used on its own without proper careful sort of consideration.
All right, thanks very much, Ben. Just conscious of the time that we'll move on to our next speaker. Our next speaker is Ms. Belinda Lambros, who's an infectious disease liaison nurse practitioner from the Department of Infectious Diseases, Peter MacCallum Cancer Centre, and the National Centre for Infections in Cancer. Belinda will speak to us today on how we can best protect ourselves and our patients from COVID-19. And I guess this is particularly relevant in the current ongoing controversy, discussion, from day to day. Do we put on face masks? Do we not? Do we wear PPE? In the light of the global shortage of PPE supply. Thanks very much, Belinda.
Thanks, Zee. So can I just check that everyone can see my screen and hear me well? Okay, so essentially I just wanted to talk to you about infection prevention during COVID-19, and Ben has given a great summary on what COVID is and what the symptoms that we're looking for. So I just will really briefly go over that. So essentially the coronaviruses are a group of viruses that can cause mild illnesses such as the common cold. And so the things that we're looking for are those respiratory symptoms and fever. And it obviously, when in the immunosuppressed patient, it could potentially turn into a pneumonia type illness. And approximately 5% will become critically ill, and 15% will have severe infection. And so what we're sort of thinking about when we're thinking about PPE and protecting ourselves is that it's actually the respiratory secretion that we want to protect ourselves and stop the spread of. So I hope that makes that nice and clear. So obviously the first thing to protect yourself and to protect other patients is knowing the case definition criteria, and you need to basically have those screening questions in that first interaction with patients, so that if they do have symptoms or they meet epidemiological criteria, that you would essentially give them a mask, step out of the room and isolate them so that they can be tested. And you want to be able to minimise your time with them, because obviously there's the 15-minute face-to-face contact. So if you do these questions in the very beginning when you're first talking to someone, then you know whether you need to step out and complete some testing, and that would be your priority. And the case definition was updated again last night. So my advice is to just have that link on your browser as a favorite, and just look at that all the time, because it is continuously changing. And so then you can move on to what you need to do with the patient afterwards. And then essentially it's just to the basics of infection prevention. So keep calm and practice your infection control. So how do infections transmit? Essentially you need to have the whole chain needs to be linked in order for the infections to transmit. So you need the causative agent, which in this case is the virus, and then you the reservoir is the person in this circumstance. And so then the next step is the portal of exit, so how the infections move about, and again, that through the respiratory secretions. So you're looking at nasal and oral secretions, through sneezing and through coughing and things like that. So having people aware about respiratory hygiene is really important, and I'm sure we have all seen those YouTube videos where you can actually see how far a sneeze can travel and where it can land. And then at that point, the next step is the means of transmission, so how they move between patients. And healthcare workers' hands are the most common, so that's why we talk about hand hygiene so much. But it's also where those droplets land, that those surfaces are contaminated. And so minimising that contamination when you touch those areas is really important as well. And then the next section is the portal of entry, so how the infectious agents enter patients or healthcare workers. And that's essentially the mucous membranes, so your eyes, your nose, your mouth. And again, that's why it's really important to do your hand hygiene prior to touching your face or your eyes or your mouth. And also it's potentially breathing in of those infectious agents as well. And then finally, as Ben very eloquently went through, it's all those patient factors, having the patient who is a susceptible host, so they can become unwell. And again, he's highlighted that beautifully, but age, comorbidities, immune status, and then also non-intact skin and their treatment and procedures. So what we want to do then, how do we break this chain? Because you have to have all of those elements in a line without any breaks in it for the infection to transmit. And so essentially what we're trying to do is just break those chains at certain points. And key steps are your standard precautions, of which hand hygiene is number one, then your transmission-based precautions, aseptic technique for procedures, and protecting yourself is being fully up to date with your vaccines, and also for your patients, for them to have their vaccinations complete as well. And then if you are exposed to, say, for example, someone would sneeze accidentally into your eye, it's knowing that occupational exposure protocol and what to do. So standard precautions. Standard precautions apply to everyone every time, and they are the first line of defence in an infection prevention and control program, and they cover these 9 areas. So we're talking obviously about hand hygiene, about the personal protective equipment, respiratory hygiene and cough etiquette, aseptic technique, safe handling and disposal of sharps, cleaning equipment between patients, particularly your reusable equipment such as stethoscopes and blood pressure cuff machines, saturation probes, those sorts of things are super important to be mindful of at the moment. And then it's having the environment clean as well, so those high touch areas. And then obviously appropriate waste management and handling of linen. So key message for hand hygiene, you can either use alcohol-based hand rub or soap and water if they're visibly soiled. Duration is always 20 seconds, and that actually feels like a really long time if you actually time it out. But a good way that we're telling our nursing staff is to sing happy birthday to yourself twice. And it's about getting into those, applying adequate friction and coverage and getting into those cracks and the other areas of your hands. And then also ensure that drying is complete before moving on to the next task, because water is also a transport measure. And always do hand hygiene before and after touching your face. So the next one is the respiratory hygiene and cough, and I'm sure everyone has seen the Department of Health posters around that, but it's essentially educating, following the steps yourself and educating patients and visitors around how to do that. And it is just covering your nose and mouth, using a tissue when possible, or using the crook of your neck or crook of your arm or upper arm, and washing your hands afterwards. And it can be either, an alcohol-based rub, or if it's visibly soiled, you should use soap and water. So now, cleaning guidelines. We're basically trying to step up cleaning as well, because of those respiratory secretions that can move around when people cough and sneeze. And so it's those frequently touched surfaces, and it needs to be cleaned with a detergent solution before using an alcohol-based solution. And also cleaning of that multi-use equipment, as I mentioned earlier. And the guidelines in the prevention and control of healthcare have got a lot of good tips. So I would recommend looking at that if you feel like you need some more information on there. And now we would move to transmission-based precautions. And so basically the transmission, we are trying to prevent the transmission by contact, droplet and airborne routes. And these are always used in addition to those standard precautions that I've mentioned earlier. And it may include a combination of practices. And as you'll see, the COVID signs, I'll go through that a little bit later. But essentially, contact precautions, when should you use them? When there's a risk of direct contact, direct or indirect transmission of infective agents. And so COVID is definitely one of those. And the risk is that your hands can be contaminated, the environment can be contaminated, and the equipment can be contaminated. And so what you should use to try and prevent that is a long sleeve fluid resistant gown and gloves, along with your usual standard precautions. And patients should be isolated into a single room if possible. Other tips are keeping notes and charts outside of rooms so that they don't get contaminated, ensuring that rooms are clearly signed. And then if you need to consider cohorting, then infection prevention should be involved. Droplet precautions. So this is when there's risk of droplet of transmission of the infection agents, and this is all respiratory illnesses and viruses, as we mentioned before. And so what to use is appropriate surgical masks, because you're trying to prevent yourself from being exposed to those respiratory droplets. And that's from a patient sneezing or coughing, or from touching the surfaces where it may have landed. And now we'll move on to airborne. So when you use airborne precautions, it's when there's a risk of those particles that are very, very small, and so they can be inhaled, and so you need to use a filter mask, which is the N95, and negative pressure room where possible, as also using the standard precautions. And it's really important to keep these doors closed so that those potential tiny ones can't move outside of the door. And examples are COVID and pulmonary TB, measles and chickenpox are some of the things that we use airborne precautions for. So on to the personal protective equipment. So obviously there's a range of things that you may consider using and be guided by these standards. And so obviously there's gowns, masks, eye protection, gloves, and theatre caps and shoe covers are things that are available. So when you are donning, it's very important, because this is the procedure that protects you from the potential infectious agent. So hand hygiene is always paramount. Putting your gown on first and then moving to your mask, and ensuring that the nose bridge is up and high. The top of the mask should always be just below your eyes, and it needs to be tight and fitted as much as possible. If it is an N95 mask, then you should complete a fit check. And so essentially, once you've got that bridge done and you've applied the lower part of the mask, you should inhale and exhale, and you should be able to see the mask move, and you shouldn't have too much leakage above and below. And there's plenty of YouTube videos on how to do a fit check for masks. And then you would add your eye or face protection, and for COVID-19 it is eye goggles are appropriate, or you could potentially use face shields depending on what your local policy is saying. But face shields are quite helpful if you've got glasses and you can't find the appropriate eye protection to put over the top. And then last of all, always do hand hygiene before you put your gloves on. And the gloves should be secured above the cuff of the gown so that there's no exposure around your wrists. Now, when it comes to removing PPE, this is where people can potentially contaminate themselves. So this is where it's super important to potentially have a buddy to spot if you're not used to these procedures, that knows how the order goes, because this is where you can potentially contaminate yourself. So there's a couple of different ways of doing it, and the recommendation by DHS is the one that I've got on the screen now. So the first thing to remember is basically everything on the outside you would consider contaminated. And so when you're taking off your gloves, you want to try and roll them and don't touch the outside of the glove with your bare hand. You need to only touch outside to outside. And then as soon as you take your gloves off, you will do your hand hygiene. And the way to remove the gown is essentially after you've done hand hygiene, you're free to undo your ties. And so you're only touching areas that are behind you. And then you would roll it down into a bundle. So essentially you're rolling it over itself. So the contaminated component of the gown is on the inside and then straight into a waste receptacle. Once you've got your gown off, you would again do hand hygiene and then remove your eye and face protection. So if you're using the standard visors, you would always reach back. You've done hand hygiene, so your hands are clean, and then you would touch the back of basically behind your ears to remove the disposable goggles or the face shield. And then if they were disposable, you would obviously put them in the bin. But if they are reusable, you should put them into a receptacle for cleaning once you're finished doffing. And then at this point, you've still got your mask on. And remember, that's the bit that's going to keep you most safe from inhaling potential infectious agents. So at this point, you would be stepping out of the zone and then taking your mask off and putting it into the bin. So for COVID-19, there's contact and droplet or contact and airborne precautions depending on what sort of procedures you're doing. This is where it comes down to, we've done sort of patient risk, but now we're also incorporating procedural risk. So I'm going to go through the DHS guidelines. So what they've recommended is droplet and contact for patients if they're suspected or confirmed. It needs to be in place while you're caring for a suspected or confirmed patient. There's a single-use surgical mask, eye protection, long sleeve gown and gloves. So that's your contact and droplet precautions. If the gown is, and so essentially it's droplet and contact for patients. And then for standard COVID patients. And then they've also made a ruling around aerosol generating procedures. So I'll move on to that. And so when airborne and contact precautions are required, you need to use the fit check, and then you would use the N95 mask, and then go on to using the other things. So examples of aerosol generating procedures are listed there. And essentially it is actioning, bronchoscopy, tracheal intubation, non-invasive ventilation, for example, BiPAP or CPAP, high flow nasal oxygen, manual ventilation before intubation, cardiopulmonary resuscitation, sputum induction, suctioning, nebulizer use, and the circumstances that you should be using these are when you are undertaking an aerosol generating procedure in a suspected or a confirmed case, when you're undertaking an aerosol generating procedure when it's not possible to determine if the case is suspected or confirmed, and when you are undertaking an aerosol generating procedure involving a high risk procedure, and those are listed. And this is all based on the current DHS guidelines. And just remember that these are changing frequently, and again, the best place to find the most current recommendations are that it's on the DHS website. So there has been a common question potentially, and that's around vaccinations, and seasonal influenza is definitely recommended by DHS, and then consider the other respiratory illnesses vaccines such as pneumococcal as appropriate for patients to ensure that they are up to date with the ones that they are recommended via the National Immunisation Schedule. Okay, and that's me. I'm ready for questions.
Thanks very much, Belinda. That was a comprehensive overview. We do have quite a few questions coming through, so I might just start the ball rolling. We have attendees from New South Wales. They were referring to the recent article that was published in JAMA regarding the distance that a potential sneeze, in terms of the droplet, the distance that the droplet can travel up to about 7 to 8 meters. In view of that, in a cancer center where we're dealing with immunocompromised patients, should we all be wearing masks to protect our patients and also ourselves from cross-infection based on this article? There may be some policy in some of the health services whereby during the flu season, those who are not immunized are asked to wear masks over where this particular health service was. So should we do that for COVID-19?
So I guess at the moment, the best advice is to follow what's currently on the DHS. And as I said, things are rapidly moving. And current advice as of late last night was, as I've outlined there, which is either goggles or a face mask. And you would always wear your airborne or droplet mask under a face shield as well, because that's sort of your basic protection.
Thanks, Belinda. So how would you also advise healthcare workers as a means of protecting their families when we go to work every day and go home? What is advice for us? Yeah.
That's a really big worry for people, and I completely understand that. And I think the main thing to remember is that this is a respiratory illness. And so it is coming into contact with those respiratory secretions that you're worried about, and that's where you need to protect yourself. So if you're comfortable with your PPE use and your standard precautions, then you know the chances of you contaminating yourself. The other things to consider are some people are talking about potentially changing clothes themselves, and you know healthcare facilities will always have those opportunities for staff to change clothes and to have showers if that's something that would make them feel more comfortable. But I think it's up to your own sort of healthcare facility to help guide you with that. There's no recommendations on DHS around that sort of thing, but it's just about those personal hygiene practices and remembering that it is a respiratory, the respiratory secretions that we're worried about. So hope that helps.
Yeah, it does. So there's one other question that's come through. Cases of COVID could be asymptomatic and still be shedding virus, and in line of what some of the other practices overseas look like. For example, in some of the European countries and some Asian countries, there is a widespread wearing mask culture amongst the public. So what's your view on that in terms of, us trying to perhaps reduce that community transmission, if at all?
So I think that obviously the evidence is emerging, and we are just guided by the current advice that's coming out through the Department of Health, and they're sort of recommending that social distancing is the biggest assistance apart from hand hygiene and your respiratory hygiene. So taking responsibility for making sure that you have those three things in place. I think that that's the key, and the Department of Health may decide to move forward and recommend to wear masks more often, more frequently. And as I said, late last night when I was preparing this talk, they actually increased the recommendations of when to use surgical masks. And it is just an evolving beast at the moment, unfortunately. But the most current advice through Department of Health website is the way to go. Sorry, Z, I can't hear you.
Sorry. Maybe perhaps one last question on the practical aspects in the day-to-day running of the Cancer Centre, where we do have equipment, with a drip stands and infusion pumps. What's your advice with regards to managing these equipment and ensure that they don't pose a risk to our patients coming in for treatment during this period?
Well, standard precautions would say that any reusable equipment you should clean down between patient use. And I think that that's something that just needs to be remembered and reiterated. It is, those are single. You should clean them in between patients, and that will assist. And also, regular changing of your personal protective equipment as per the standard precautions requirements.
All right, now thanks very much, Belinda. Now, I'm just conscious of time that we're nearly coming up to the hour. I'd just like to thank again our two panelists, for an hour of very interesting and engaging information on COVID-19 in our cancer patients, as well as the staff from VCCC who worked on the technology to make this event possible. I also like to thank everyone who dialed in. We had a record of just under 300 attendees, and I hope you've enjoyed the session and found it useful, as I have. I just wanted to let you know that we do have upcoming Monday lunch webinar in the next 2 weeks after Easter. There will be a special edition coming up on 20th of April on COVID-19 and cancer in Victoria, and on the 27th of April on Staging the Aging, Vital Lessons from the Monash Geriatric Oncology Service. And we all look forward to seeing you again in the upcoming events brought to you by the Victorian COVID-19 and Cancer Network. Thanks very much for dialing in, everyone.